I'm arguing that colorblind approaches to public health are harmful because they hide real racial and ethnic health disparities. Colorblindness may sound fair, but it blinds us to the evidence that we need to protect communities. During COVID-19, many states failed to track race, which delayed the discovery that certain groups were being disproportionately affected because of that. Resources did not reach the communities that they needed the most. Colorblind policies also violate public health ethics, which require justice and prevention of harm. Ignoring race pretends everyone has the same opportunities for health when, in reality, racism has shaped housing, income, and access to care for many years. Finally, race-specific data leads to better outcomes, like reducing maternal mortality for Black women and improving diabetes control through culturally tailored education. Colorblindness may sound fair in theory, but in practice it makes public health less accurate, less ethical, and less effective. First, colorblind policies lived erase realities and specific health needs for different racial and ethnic groups. When we fail to collect or analyze health data by race, critical disparities stay hidden. A clear example comes from the early COVID-19 pandemic, when many states do not track race or ethnic data. Because of this, it took far too long to realize that Black, Hispanic, and Indigenous communities were being disproportionately affected. These delays slowed targeted response and allowed preventable harm to continue. When public health ignores race, it ignores evidence, and communities pay the price. Second, colorblindness violates core public health ethics. Justice and beneficence require us to recognize inequities and prevent harm. A colorblind framework claims neutrality, but neutrality in the face of inequity is not ethical. It protects the status quo. Systems shaped by racism have long affected access to health care, income, housing, and education. The Public Health Code of Ethics tells us that justice means ensuring each person has what they need to maintain health. Policies that pretend race doesn't matter fail this duty and actually perpetrate discrimination. Third, acknowledging racial and ethnic differences leads to better, more targeted health policies and improved outcomes. Programs that use race-specific data, such as targeted maternal health interventions for Black women or culturally tailored diabetes education, produce measurable improvements. Recognizing race allows health organizations to properly allocate resources, partner with trusted community leaders, and rebuild confidence in public institutions. This isn't divisive, it's responsive, evidence-based, and necessary. Now, some may argue that emphasizing race is counterproductive and that it divides people or reinforces stereotypes. Others say that it should be universal or that socioeconomic status matters more than race. But ignoring race doesn't unify people. It conceals the inequities that divide us. During COVID-19, race-specific data wasn't about assigning blame. It was about accuracy. It saved lives by showing who needed support most. And while socioeconomic status is important, it deeply intertwines with race due to the long-standing structural inequities. Public health cannot address one without acknowledging the other. Treating everyone the same is not fairness. Equity. Giving communities what they actually need is fairness. In conclusion, colorblind approaches to public health do not create equality, they obscure the truth. Real progress requires acknowledging racial disparities so we can design interventions that are ethical, informed, and effective. Public health cannot be colorblind because people's lived experiences are not colorblind. If we want better outcomes for everyone, we must confront inequity directly and not hide from it.